Okay, everyone, it's 15:08. Welcome. We're about to start. This is Dr. Obi, one of the personal physicians in Cardiocare, and with me is consultant physician Dr. Awofisoye, consultant endocrinologist. So we're about to start, and we'll be using this. Okay.
So basically, we'll be going with this outline. We all agree that thyroid dysfunction is very common.
Yes.
I'm not sure how often we see this kind of patients in our practices, but thyroid dysfunction are quite common. And very sadly, they are missed many a times even by experts. And that's part of the reasons why we're discussing this topic, particularly at this time.
By the end of this presentation, we hope that we have learned the basics and how to not miss such cases if it comes to our facility. So just have a note on the paper close by, because it's going to be very interesting and educative webinar. So we'll kick off with a case presentation. So a 36-year-old lady that presented with palpitations, fatigue, and poor sleep. She partly attributes this to stress from her recently changed job roles. And she has been treated for malaria twice in the last 6 weeks, despite testing negative one of those times. So a diagnosis of stress and anxiety disorder was made, and she was prescribed bromazepam and vitamins. She felt a bit better, but her sufferings mostly continued.
Now, I'm sure that this is a very common clinical scenario. I see patients like this frequently anyway, every week, every day. You see patients complain of what looks like non-specific symptoms, so to say. And then many of them, you just attribute their symptoms to one thing or the other. Sometimes they get better, but many times the symptoms just continue. And I will expect that many of us will agree that many times these kind of patients can be challenging. Many of these patients is just stress, some psychological issues and things like that. But amongst these patients lie a number of patients in which the thyroid is actually the problem. And the certain about this is that it's actually quite easy to diagnose, but we miss it. Why? Because we were not thinking about it. And I remember a particular patient has been managed for anxiety and all sorts of different things for like maybe up to 2 or 3 months, until someone decided it wasn't a doctor that even told him to check the thyroid function. Someone told him to check the thyroid function, and then lo and behold, he did it, and he went to show the results to his doctors, and the doctors felt very disappointed. Why? How come I didn't think of this? Well, that was a guy actually, but in this case, this is a lady. And we're going to be looking at the things that should help us have an high index of suspicion for the existence of thyroid diseases, and then how we should approach making this diagnosis, evaluating the patient, and then managing the patient. So we'll just jump right into it. So talking about the epidemiology of thyroid diseases, there's a lot of things that come into consideration straight away. I'm not sure when last you saw a patient with thyroid disorder, maybe hyperthyroidism, but you can think of the age, you can think of the gender, then you can think of the family history. Out of these first 3 things, what makes someone at most of risk to thyroid disease based on your experience, Dr. B?
Find out that the female gender.
Absolutely, I think that's the most important thing. So females are more prone to thyroid disease, just generally speaking, and we know that thyroid disorders are way more common in female. For example, Graves' disease, which is very common, is 10 times more common among females. Okay. Now that said, we also know that the few times we see, or the less time that we see thyroid disease, particularly thyroid toxicosis among males, it tends to be more severe many a times. Also, thyroid diseases, depending on which one we are talking about. So this afternoon, we're talking about hyperthyroidism, for example, is more common among females of the reproductive age group. So we're talking of people between the ages of about 20 and mid-40s. That's more common among them. If you're talking about things like thyroid nodules, it's more common among people in the reproductive age group, but it's also common among elderly subjects as well. Okay. Hypothyroidism prevalence increases as people age. Okay. Family history is also important. So in people who have family history of thyroid diseases, incidentally, about maybe a week or 2 ago, I saw a lady that had hypothyroidism. She came in from some of the states in the north. I won't mention the state. And then 2 of her relations has hyperthyroidism. One was just hyperthyroidism. The other was actually thyroid malignancy. So family history is important for many reasons. And of course, we have this disparity between the spectrum of thyroid diseases we see in areas that are iodine deficient compared to areas that are iodine replete. I'll give us a bit of background of that. So for example, in Nigeria, a lot of areas in Nigeria where iodine deficiency, particularly in the heifers, iodine deficiency, and that's when we used to talk about the goiter belt, okay? The nature of thyroid disease you see in those areas is quite different from what you see in areas that are iodine replaced. And that's why even the epidemiology of thyroid disease in Nigeria has actually evolved over the last few decades. So in areas that are iodine deficiency, you tend to get a lot of endemic goiters and predominantly goiters, less of autoimmune thyroid diseases, whereas in iodine replete zones, you're more likely to have autoimmune thyroid diseases, which is dominantly Graves' disease and of course, Hashimoto's thyroiditis or chronic atrophic thyroiditis, okay? So that's aside, we also know that a lot of the thyroid disorders are autoimmune in nature, okay? And autoimmune disease tend to cluster. So when you see one autoimmune disease, you should look for the others. So you see someone having vitiligo, people having type 1 diabetes mellitus, you should think of thyroid disorders, and they are not usually very far. Now, oftentimes, many either autoimmune or hormonal-based disorders like this, they tend to have environmental triggers. And because of that, environmental triggers such as infections, such as pregnancy, such as stress, emotional distress, tends to cause, tend to trigger thyroid diseases. So these are things we should look for and should be conversant with when we are evaluating people for potential thyroid disorders. So I think
next that will be on the epidemiology of the thyroid disease.
Absolutely. So it's important to know that 1/3 of the world population live in thyroid deficient areas. Yes. A whole 1/3 of the population of the world. And that means you don't have to think so far before you imagine that. And of course, as I mentioned earlier, that Nigeria, a lot of the areas in Nigeria were thyroid deficient, but since salt replacement has started a few decades ago, most of us are getting sufficient iodine from our diet actually. And you can see the prevalence of hyperthyroidism on this slide. 0.5 to 2% of females will have hyperthyroidism at some point in their life. I did mention earlier that particularly for Graves' disease, female to male ratio is about 10:1. And I'm sure most doctors, you think of about up to 10 females you can remember with hyperthyroidism, or you can think of a single male you say. Okay, thyroid nodules are also very common. Again, far more common in females, more common in areas with iodine deficiency. Also, thyroid enlargement, bits of physiological happens in pregnancy as well. And now we have this subclinical component. We talk about subclinical hyperthyroidism and hypothyroidism. Subclinical hypothyroidism is more common, of course, compared to hyperthyroidism. And again, the incidence of hypothyroidism, both clinical and subclinical, increases with aging. Okay, so by the time people are up to about 70 or 80 years old, a good fraction of them will have significant hypothyroidism. So we should just put that in mind. And by the time you see an elderly woman with certain symptoms, forgetfulness, cold intolerance, you should not think far because you ask yourself whether this patient could be hypothyroid or not. Okay. Okay. We also talk about the goiter belt in Nigeria, and there's a map which I'll show on the next slide, which shows areas in which we've had hypothyroidism in the past. Okay, but as I said earlier, since iodine replacement in iodine supplementation in salt and other meals has been done over the years, iodine deficiency rates and also goiter rates in the country has reduced significantly. I think way back in 1993, a prevalence of a goiter rate prevalence of about 20% was quoted then, and about 20 million Nigerians were thought to be affected by iodine deficiency. But of course, this has really increased by now. And of course, in 2007, Nigeria was judged to be overall iodine sufficient, even though, of course, public health measures to ensure iodine sufficiency needs to be continued over time. I think I need to be a bit faster now. So in terms of clinical presentations, and now this is where, now look at the fourth line here. Hyperthyroidism actually, in terms of patient that presents clinically, hyperthyroidism, you see hyperthyroidism in clinic more often than you see hypothyroidism. Okay, and this from a series in, I think was somewhere in the south to south, I can't remember where that study was done. Okay, but hyperthyroidism, you see that more often in clinic. Now, globally, epidemiologically, hypothyroidism is actually way more common than hyperthyroidism. That is true. But the symptoms of hyperthyroidism is more likely to be troublesome to the patient, and those patients are more likely to present in the hospital compared to hyperthyroidism. Okay, so in clinic, we are likely more to see more of hyperthyroidism, some hypothyroidism, and then the SCS stands for sick uterus syndrome, that or uterus sick syndrome, in which someone has a non-thyroidal illness, but that is enough to cause some abnormalities in the thyroid function test. So those are the common things we see. That's a presentation of patients with thyroid dysfunction. Now, among patients with goiter, if you see a patient with goiter on the road, it's most likely going to be a simple goiter. So the commonest is simple goiters. Some of them will be toxic. Some of them, which is usually less, at least from the series we have in Nigeria, will actually be hypothyroid, despite the fact they have a goiter, but that goiter is hypothyroid. And of course, sometimes a goiter can be from thyroiditis, and one of the salient features of thyroiditis is tenderness, either at that time or sometimes in the past. And of course, among people you see with goiter, some of them actually are harboring some sort of malignancies in the thyroid gland. So we'll put that in mind, and these are actually from some studies that have been done previously in Nigeria. So this is some prevalence of goiter in different parts of the country at a time in the past. This was in 1993. You can see that in the southeast zones, Benue,
and Cross River,
you have the highest prevalence, and then the lowest prevalence possibly around Delta, Bayelsa, Rivers, at that time.
Lagos, Ogun. Okay.
At that time. So, but iodine deficiency is a common cause of the simple and common goiter that we see. And of course, just taking a normal amount, a regular diet, adequate amount of seafood, adequate amount of normal salt, usually will ensure that we are taking sufficient iodine in the diet. Because there's come the challenges of patients who have hypertension or heart issues and they are low salt diet or no salt diet. Sometimes you may need to make conscious efforts that they're getting the amount of iodine they need in their regular diet. So what's hyperthyroidism, Dr. Obi?
Okay, hyperthyroidism is just usually due to the activity of active thyroid gland, meaning the hormone, thyroid hormone is raised.
Absolutely, absolutely. So if we say someone is hyperthyroid, the gland is overactive, it's working too much and it's releasing too much hormone into circulation. Now, thyroid toxicosis is often used interchangeably with hyperthyroidism. Okay, but hyperthyroid toxicosis actually just refers to the clinical syndrome. That is what happens when the body is flooded with too much thyroid hormone, and that's usually in the form of T3 and T4, okay? So the commonest cause of thyroid toxicosis is hyperthyroidism, but theoretically and in practice, actually, you can have some other causes of thyroid toxicosis apart from hyperthyroidism. So that's important for us to know. This slide, I will just be fast on this slide, shows us a bit about thyroid hormone synthesis. The most important thing for us to know is that thyroglobulin is produced in the tissue in the follicle, and of course it's exocytosed into the colloid, where its iodine is added onto it through some process we call iodination, and that is governed by TPO, that's thyroid peroxidase. That forms MIT with a single iodine and DIT with double iodine, and these are coupled to form T3 and T4, which is further stored in the colloid, and of course is released as needed into the body. The most important thing for us to know about the physiology of thyroid hormone synthesis is number one, it's an iodine-dependent process. It needs iodine. That's the currency of the thyroid gland. So iodine is needed for it. That's one. Secondly, it is governed by the thyroid peroxidase enzyme. And then thirdly, preformed thyroid hormone, both in form of T4 and T3, is stored in the thyroid gland and is released as needed. Okay. TSH, which is the governing hormone for the thyroid gland. The TSH governs both the process of iodination and also of the release of the T3 and the T4. So if you put those things in mind, one will easily understand how the thyroid does its moment-to-moment functioning. Okay. Now, regulation of the thyroid hormones. We talk about the thyroid axis, and that's one of the key basic principles we teach in endocrinology. So we have that axis, the thyroid axis. Talk about the hypothalamus upstairs, the pituitary gland in between, and the thyroid gland downstairs. And we have those oversight processes and then the negative feedbacks. Okay, so the TSH is released by the hypothalamus, makes the pituitary gland to release. Sorry, the TRH is released by the hypothalamus, make the pituitary gland to release TSH. That's the thyroid stimulating hormone, which stimulates the thyroid gland and that makes the thyroid gland produce T3 and T4, both in terms of synthesis and release, okay? And this T3 and T4, by the time the concentration gets to a certain level, it goes to inhibit the release of TSH by the pituitary gland, and also somehow weaker release of TRH by the hypothalamus. So that is basically the thyroid axis, and that regulation works very splendidly in physiological states. But of course, in disease states, we have issues, and those are part of the issues we're going to talk about in the afternoon. So again, hyperthyroidism refers to the thyroid gland that is overactive, that is producing more hormone that is needed, okay? Now, if you look at this chart, if the chart is working properly, okay, if the thyroid gland produces more hormone that is needed, normally, if it should go back to inhibit this TSH production here, and then TSH should reduce. That means stimulation of the thyroid gland should reduce, and the T3 and T4 should fall. Okay, but it tells you anytime that you have hyperthyroidism, there's a failure of regulation, just like we have a failure of governance in some society. I won't mention the name of any society now. So there's a failure of regulation. So anytime you have a patient having sustained thyrotoxicosis particularly, there must have been a failure of regulation, because if this process works very well, there are checks and balances to make sure that thyroid hormone does not get to, and that leads us into an etiology of hyperthyroidism. So talking about the etiology, what's the commonest cause of hyperthyroidism?
There are various causes.
What's the commonest?
Autoimmune.
Absolutely. So the commonest cause of hyperthyroidism is actually autoimmune, and that's Graves' disease. Okay. So that's important for us to know. Commonest cause of hyperthyroidism is autoimmune, and that's from Graves' disease. Now, we have many other things that can make a patient to be hyperthyroid. Someone can have a solitary nodule, which is functional, okay? People can have thyroid nodules that may not be functional, okay? But if the nodule is functional, then it can give you hyperthyroidism. Someone can have multiple nodules and that are functional. All of them do not have to be functional, but by the time you have many that are functional, that gives us a toxic multinodular goiter, right? Okay. We can also have hyperemesis gravidarum, which is a very common condition. It's largely HCG mediated, and like we will learn earlier during the discussion, HCG and hyperemesis gravidarum can be associated with hyperthyroidism in pregnancy. Okay. We also have what we call acetoxicosis. Okay. Acetoxicosis is a concocted word, that's Hashimoto's toxicosis. So in the earliest, Hashimoto's thyroiditis is a form of thyroiditis, and it's the commonest cause of chronic hypothyroidism actually. But in the early phases of Hashimoto's thyroiditis, you can actually have a toxic phase in which there is a release of a lot of preformed hormones by the thyroid gland and inflammation in thyroid glands, which will now later burn out to a hypothyroid phase. So in that early phase, you can actually have hyperthyroidism. You can also have other forms of thyroiditis, which is common, also which is widespread, and we should not miss it as much as possible. In thyroiditis, the thyroid is actually not overactive. In fact, it's likely underactive. Okay, and most of the hormones that you have flushed out into the system in thyroiditis are preformed hormones. That is the T3 and T4 that's been made already by the thyroid gland, but they're not really making any new ones. So it's almost like a printing and minting company that are not making any currency anymore, but they just release all the ones they have in the circulation. You think you have money, but usually after a few weeks time, you just see that you're bankrupt, that is, and there are no more hormones to be found. And that part of the things that guides us in the way we treat thyroiditis. So you can have thyroiditis from infections, commonly viral, sometimes bacterial. You can have what we have called the Quebec thyroiditis. We can also have postpartum thyroiditis, which is quite common. You can also have drug-induced thyroiditis, can be induced by drugs such as amiodarone, lithium, can also be induced by radiodine-containing contrast, okay? You can also have trauma-causing thyroiditis, and we can also have radiation. So you radiate the neck for one thing or the other. Maybe you're even radiating thyroid cancer, and then it can cause thyroiditis that can lead to release of a surge of hormone into the circulation, and the patient can present with thyrotoxicosis, okay? We can also have excessive thyroid hormone replacement. So if you have a patient that have hypothyroidism, for example, and then you give a certain amount of levothyroxine that is too much, then can actually have feature of thyrotoxicosis, okay? Most thyroid cancers are not functional, but sometimes you get a rare functional one that is actually producing T3 and T4 efficiently, maybe even producing too much. The patient can have features of hyperthyroidism. You can have other tumors that produce TSH on their own, and the TSH, which is coming from outside the pituitary gland now. So such tumors include what we call struma ovarian. So it's a form of, we call it So it's a form of paraneoplastic syndrome. So a ovarian malignancy that is now producing TSH, and the TSH now goes from the ovary and now goes to the thyroid to go and stimulate the thyroid gland to do that. Okay. You can also have secondary hyperthyroidism. Stromal ovary is a form of secondary hyperthyroidism actually. You can also have secondary hyperthyroidism from, these are rarities, so I don't think we should go into them so much. So, but we should know that there's a wide spectrum of cause for hyperthyroidism, and it means that when you see that patient presenting with features of thyroid toxicosis, you should ask yourself, what's the cause? Now, while we have said that autoimmune causes are the dominant causes of this, it doesn't mean that we can assume this, and that means you have to actually try to find out the cause. But go back to our case scenario now.
Okay.
We don't need to move to slide. We should remember that if a patient has hyperthyroidism, they are not likely going to come to you and say that they have hyperthyroidism, and they can present in various ways. So we're going to look at the typical ways, various ways they present now. They can present with typical symptoms, and that's a medical student can diagnose. Okay, but like you can see in the case scenario we gave earlier, the symptoms may not be typical. Actually, it may not be typical. The patient can just present with some other symptoms by the side. And in those cases, it takes you to have a very high index of suspicion to say that, wait, this could be thyroid, or could this be thyroid? And taking that pause to ask yourself a question, that question is all you need, because altering for a thyroid function test is not difficult, and usually we get reliable results in a little time. So it's just for us to think of it in the right way, okay? Sometimes you check for hyperthyroidism while surveilling someone on other treatments. That's someone that has other autoimmune conditions, or someone that is on hypothyroidism treatment, and then you check and you see that this person's hormone is now too high. Okay, some people pick it on routine medical checkup. That said, it's more common for you to pick hypothyroidism on routine medical checkup than hyperthyroidism. Subclinical hypothyroidism is more common, and then the symptoms of hypothyroidism are more likely to be more subtle compared to the symptoms of hyperthyroidism. Most patients with hyperthyroidism will present in the hospital actually, and you are less likely to pick it on routine medical screening compared to hypothyroidism. Okay. So what are the symptoms of hyperthyroidism, Dr. Obi? When last did you see a patient with hyperthyroidism?
That should be 2 weeks ago.
2 weeks ago. Yeah. All right, really. Okay. Yeah. So can you remember 3 symptoms that patient had?
Okay. The patient presented with palpitations, okay, with tremors, and she presented with marked weight loss. Okay, so I think those are very common symptoms of hyperthyroidism actually. If I had those symptoms, I think my head would click that this may be hyperthyroidism. So we have a chart here that talks about some of the symptoms of hyperthyroidism. I'm not sure what your experience has been. Can you go through the symptoms for us, please? Okay, so we have the general symptoms, which can present as, patient can present with weight loss, malaise, or osteopenia.
Okay, so osteopenia it should actually be under musculoskeletal. Yes. Okay, but now weight loss and malaise are extremely very common. But by the time you see weight loss in a female in the right epidemiological circumstances, let me frame it like that, okay? That means a female of 32-year-old, for example, comes to you and say that I'm losing weight.
And it's not intentional.
Hello. In fact, there's someone I saw recently that, she needed to lose weight because she was big before, but she knew that the weight loss she got was not from her efforts. She was not really doing much, and then she was losing weight. She was happy. But man, she was like, her pulse rate was exceeding 120, it was about 124, 128. So she had that tachycardia and all of those gross hyperthyroid symptoms there. So weight loss, when you hear weight loss, we should think thyroid amongst other things, particularly in a young person in the right age group.
So we can have some skin manifestations such as rashes, they may be itchy, pruritus, some changes in skin color.
Okay, so that's hyperpigmentation of the skin is actually quite common. Okay, many times you just see them get just really darker, and by the time you treat them, the darkness improves. So if you see that skin hyperpigmentation, we should think of it. So nail changes, the commonest one is onycholysis, which is separation of the nail from the nail bed. Okay, sometimes we also can have finger clubbing, which is quite common. Okay, there can also be hair thinning and hair loss, so the hair can be a bit fluffy. Hair loss is actually slightly more common with hypothyroidism than hyper, but you can have it in both. And of course, the person can be sweating excessively. Again, it's for our antenna to be up. I'll tell you that the proportion of patients that present with classic symptoms, there's no patient that will present with all the symptoms there. Know that. In fact, there's no patient that will present with a third or a quarter. Okay, but by the time you get a few of this, we should have a low threshold for suspecting a thyroid and for checking for it. Okay, palpitation is a very common symptom.
Yes, very common.
Absolutely, and they can also have things like atrial fibrillation, shortness of breath, breathing edema as well. What are the GI symptoms they can have?
They can come with diarrhea, hyperphagia, or jaundice.
Okay, so the diarrhea is actually technically hyperdefecation. That is, the consistency is not necessarily that loose. But by the time you get the patients that tell you that they have chronic diarrhea, they go to the toilet about 3 or 4 times a day. Now, a good number of these patients will be irritable bowel syndrome, that's IBS, okay? But the ones, in fact, before you label it IBS, you should check the thyroid function. You should check the thyroid function test, and we'll talk about how to do that along the line. Of course, neurological symptoms are extremely very common among thyroid patients, and they're often anxious, restless. In fact, most of them are diagnosed with anxiety disorder. Some of them actually have anxiety disorder apart from the thyroid dysfunction. But in every person with diagnosed with anxiety disorder, have you checked the thyroid function tests? Okay, we should not forget that the symptoms of thyroid toxicosis and that of anxiety, they overlap quite a lot. And in fact, the peripheral manifestation of hyperthyroidism are actually quite related to the adrenergic system. Okay, so there is a increased sensitivity of the body to adrenaline. So it's those fear and flight symptoms that they have. So restlessness, tremulousness, insomnia. Of course, sometimes it can be bad enough to cause psychosis. Some people can have what can look like dementia. This is one of the negative symptoms you can have in elderly subjects. And it's one of the causes of proximal myopathy, in which someone just has weakness of the proximal muscles. Okay. What are the eye features?
We can have proptosis when the eyes pop out. You have gritty sensation. It can be itchy, come with red eyes. They may experience diplopia or blood vision.
Okay, so proptosis is very common and I think I want to expect that most of us, if you see a patient complaining of bulginess of their eyes, or their eyes is looking different, that will remember to check the thyroid function. They may or may not have a goiter. Don't forget that patients can have hyperthyroidism without necessarily having a goiter. They may not have a clinical goiter. In fact, you can do an ultrasound scan and the thyroid can look just nice and normal. Okay, most of them will have abnormalities on thyroid imaging, but the absence of a clinical goiter should not make you exclude a possible diagnosis of hyperthyroidism. So that's very important. Now, also know that most patients with hyperthyroidism may not necessarily have eye signs. Don't forget that the eye signs they have in Graves' disease can precede, come at the same time, or come after the onset of the systemic toxic symptoms. Okay, but by the time you have someone complaining of unclear structural eye issues like proptosis, grittiness, diplopia, or the eyes are somehow, please think of the thyroid. Okay, they can also have periorbital edema. It's not here on this slide, so they can have periorbital swelling. Okay, so of course, reproductive symptoms are quite common. What's the commonest reproductive symptom?
Menstrual irregularities.
Absolutely. So menstrual irregularities are very common with that. In fact, now I'm not sure what proportion of patients with hyperthyroidism will have menstrual irregularities, but I would dare say possibly up to half of them. Okay, so menstrual irregularities are common and it can make someone to be subfertile. So, and I'm happy that routinely in gynae clinic, at least one in Hospital CBD and most gynae clinics, routinely will check thyroid function if someone complains of infertility. Reduced libido is also common, and gynecomastia may also be seen among males as well. So, summarily for this, the diagnosis will typically require a high index of suspicion. You can see that this dog is looking at you in a suspicious manner. That's something going on here, and then you should ask your patient that is it the thyroid? Okay, and again, thankfully, these are things that we can check very, very easily. So, I think in examining a patient with thyroid dysfunction now, or possible thyroid dysfunction now, I'm sure this woman's face just says it all. They can have periorbital edema, they can have bleed traction, they can have bleed lag. I'm sure we know what those are. They can have proptosis, they can have some corneal exposure. Okay, so lead retraction is for you to, in someone looking at the neutral level. So they're looking at the same horizontal level as their eyes. They're looking just straight ahead. If you can see the sclera just above the pupil, there's some lead retraction, okay? And then lead lag you check by testing gaze, vertical gaze, okay? Usually if you get I was trying to get a video before, but I couldn't get it on time. If the lead is lagging, the movement of the hind leg is lagging behind the movement of the high balls, particularly when looking down, then you can say that there is lead lag, okay? So that's lead lag, okay? So the eye features are common, but you have to look for it. If you don't look for it, you won't find it. The best way to look for proptosis is to go behind the patient and look from the forehead and see whether you can see the bulge of the eye above the suprarbital feature. Okay, there's what we call the something meter that we use to actually formally assess for that, but usually we don't use it routine in clinical practice. Of course, you need to look at the thyroid gland. There are lots of things you need to look at the thyroid gland. You need to know whether it's enlarged or not. Okay, that's one. You also need to know whether it is fused or not fused to the overlying and underlying structure, because that's what will make us suspect whether there's a malignancy or not. It's also important for you to check whether there's any tenderness. Okay, if you're examining a thyroid in the context of someone that seems to be hyperthyroid and the thyroid gland is tender, it is thyroiditis until otherwise stated. Okay, and the management for that is different, generally speaking. Okay, of course, you want to look at the patient's pulse. Typically, they can have a fast pulse. That's the general thing you're going to get. The pulse can be bounding in character. Okay, it can even be collapsive, but it can be bounding. That means there's a very high and there's very low. So it's swinging between those ends. It might be regular, either with just atrial and ventricular ectopics, or it might be irregularly regular to the extent in which you see in someone that is already having atrial fibrillation. Atrial fibrillation complicating hyperthyroidism is more common in older subjects. Okay, so older subjects, and you have to look for it, because if you don't look for it, you won't find it. If you don't find it, the patient might have a stroke before you even know that the patient has atrial fibrillation, which is not nice. Okay, of course, in the fingers, we like to demonstrate the tremors, which is usually fine. You typically will place a piece of paper on it so that you can see it shaking very well. It can be supports the diagnosis that you're considering. Any other thing that is really important to find on examination, Dr. B?
You can also look at the CNS, the reflexes.
Okay, so the reflexes can be brisk, even though that's more for academic purposes. They can have pedal edema. It's good to check the heart as well. Thyrotoxicosis can cause what we call thyroid cardiomyopathy or thyrotoxic heart disease, and they can have heart failure as well. So you need to check the heart very well so that you know how aggressive you should be with that patient's evaluation and investigation. So going further now, I've said that goiter is often present, but its absence does not invalidate the diagnosis of hyperthyroidism or your suspicion. So if you're still suspicious, please check the thyroid function test, get the imaging of the thyroid gland, etc. Okay, we'll talk about the highs. Okay, so there can be presence of thyroid eye disease and the other signs of adrenal overactivity. The lead gland and retraction are actually more for adrenal overactivity. By the way, by the time you have either proptosis or periorbital edema or the grittiness or other eye features, including ophthalmoplegia. So that ophthalmoplegia is weakness of any of the eye movements, which is one of the known complications of thyroid eye disease. It tells you that there's thyroid eye disease, and more importantly, is typical of Graves' disease. Okay, so it tells your diagnosis just from a general diagnosis of hyperthyroidism towards Graves' disease, which has its own specific pathophysiology and prognosis. Okay, of course, we'll talk about the hyperpigmentation and all of that. We'll talk about the CNS features. We'll talk about the respiratory features. So typically, they can have the resting tachypnea, and of course, please let's note that one of the differential diagnoses of someone complaining of dyspnea, particularly dyspnea and exertion, hyperthyroidism can definitely cause that. Okay, and we should check for such in those patients. In our center here in Cardiocare, we check thyroid function tests routinely in patients present with heart failure. Okay, and it has given us quite a lot of reward actually, because if you correct any thyroid dysfunction, be it hypo or hyper, the patient will fare better. Right, so this the high in hyperthyroidism. Again, I've said it repeatedly. Eye signs will be absent, goiter may be absent. Okay, the high signs can come with, before, or long after clinical thyroid disease. Okay, and a lot of eye issues you can see as well. Listed them all here. Don't wait for reduced visual acuity. That's usually a very late finding. Okay, so in this eye up here, you can see periorbital edema. So the eye is quite baggy. Don't take it to be because patient did not sleep well or because something else. No. Okay. Periorbital, in fact, it can be the only feature. So, okay. So if patient comes to you with just bulging of the eyes or periorbital edema that is not explained by any other thing, please check the thyroid function test. Okay. And of course, I'll talk about lead lag and retraction. So I think we can move on from there. Yeah. So the thyroid gland itself, we'll talk about this. The things you want to look at for you, inspect from the front, first of all. You want to see whether there's any focal swelling of the thyroid gland or a diffuse swelling of the thyroid gland. It's important for you to see that. And of course, while inspecting from the back, after doing all the other things, going to swallow water, you want to check for the texture of the thyroid gland, and that you do by palpating the thyroid gland itself. Is it firm to touch? Is it soft? Is it hard? Okay. Are there nodular areas? You want to check for all of that. Is it tender? Okay, it's critical for you to know whether it is tender or not at that time, and ask the patient whether it has been tender before. Okay, we want to check by percussion of the sternal area whether there's any form of retrosternal extension. And of course, there are many other things to check there. Don't forget that apart from retrosternal extension, the things that tell you that there may be retrosternal components is the patient is having difficulty swallowing, discomfort swallowing. The patient is having noisy breathing at some points. You want to really assess that very well. There's something we call permitting sign. Can you remember permitting sign, Dr. Obi? So permitting sign, you ask the patient to raise the 2 hands up, and then you can have sufflation of the face. Okay, so and that tells you that there is already some compression of the veins of the neck. Okay, so it causes sufflation of the face gets swollen, pain. It's usually more noticeable in Caucasians with lighter skin. Okay, but it's something that we should know how to check for. It's also important to check for lymph nodes. Okay, if you find lymph nodes, particularly hard lymph nodes, it's one of the things that can make you to suspect that are you dealing with a malignancy here. Okay, but of course that's never a conclusive evidence, and that means usually you need to do more workup. Infiltration into surrounding tissues will be worrisome. Okay, most time when you feel someone having a thyroid enlargement, you can feel the sternocleidomyoid muscle separately from it. You can move the skin over it. You can move it away from around the surrounding tissues. But by the time it's fixed to the surrounding tissues, you're worried. And in those cases, you may need to do an FNAC. Of course, a brew is important to look for. In overactive thyroid, like hyperthyroidism, hyperthyroid Graves' disease, an audible brew is often common. And that tells you, again, because a thyroid is a very vascular structure.
So yeah, it's like 20 now. Should we take some questions?
Okay, so let's see whether there's any questions. So please, if you have any questions, please put them in the chat box, and we're going to take them along the line. Okay, so I think we just have a few questions for now. This can wait for now, actually. So please put your question in the chat box, and we'll answer them as time goes on. Okay. So let's go to the next slide, Dr. Obi. So investigations.
Yes.
Okay, so before we go to investigations, any key thing that we've missed out, and we'll talk about how the patient typically presents, the things we need to ask, the things we need to evaluate for at least clinically by the time we're seeing the patient. There are a lot of questions to ask the patient, which I really didn't go through in the history. I think we'll focus a lot more on the symptom. Okay. And but I think it's very important for us to highlight the dominant symptom or the dominant problem of the patient so that can always be addressed. Now, going to investigations now. So investigations, there are a lot of tests we do for this patient. I mean, the very first basic test that you need to be able to do is thyroid function test, okay? So thyroid function test is made up of TSH, T3, and T4. Some centers do total, which is fine, but free is generally preferred, okay? Free, the free hormone is, so we know that thyroid hormone, most of it is bound to protein. The part that is bound to protein, which is albumin actually, is not active, okay? Not just albumin, there are many proteins it binds to, but it's not active. The free segment is the part that is active and that is responsible for the clinical syndrome that the patient has, okay? So the free hormones is actually generally more preferred and more useful, and most assays that are done now are done based on the free hormones. So we have other tests here, full blood counts, inflammatory markers, liver function tests, autoimmune markers, sometimes thyroid ultrasound scan, radioactive iodine uptake. Then sometimes in very select cases, you may need to do the fine needle aspiration cytology, ECG, echo, and sometimes you need to do some other hormones as well. So those are the investigations. We'll go through some of them a bit now.
So this is a slide on the thyroid function test interpretation.
Okay, so for hyperthyroidism is the first line, Abby. Let's go through that first.
So if you have a low TSH, but when you do your free T3 and T4 and T3, they are high. That's the clinical picture of hyperthyroidism.
Absolutely, and that's the part that we are most interested in at this time. So hyperthyroidism, some people, particularly laymen, they expect the TSH to be high, or they're treating one component of the hormone. And I remind us that when we interpret TFTs, we interpret the three in synchrony. We interpret them together in the context of each other, and we don't interpret them in isolation. No, okay. So again, in hyperthyroidism, your T3 and T4 high, and then the TSH is low, and they go hand in hand together. Sometimes you get the T4 being normal, okay, and that's the so-called C3 toxicosis. Okay, so sometimes the T4 can be normal. Don't forget that most of the hormone that is produced by the thyroid gland is actually T4. The thyroid gland produces less of T3, and it's in the periphery that some T4 is converted to T3. The T3 is the one that is most or more physiologically active. So put that in mind. Subclinical hyperthyroidism sometimes occur, but we don't usually make too much fuss about it. Of course, you can always have thyroiditis. You can have thyroiditis. In thyroiditis, the both T4 is the one that is most elevated. T3 can be normal, okay? But sometimes both can be elevated. But don't forget what we said earlier, that the one that you have more preformed version of in the thyroid gland is T4, okay? Also, in someone that has T4 injection, that's factitious hyperthyroidism, now that's the T4 injection. You can have predominantly T4 elevation, and the T3 can be quiet, either normal or not so elevated, okay? Of course, we have the uterus 6 syndrome. In the uterus 6 syndrome or sick uterus syndrome,
all parameters are low.
All parameters are typically low, and that's usually occurs in the context of a severe intercurrent illness that just depresses many aspects of the thyroid function from a secondary or even a tertiary perspective. So that's just there. I won't go into the part of the others. So let's just move on.
Okay. So talking about the autoimmune markers.
Okay, so before I go to the autoimmune markers, so when you see a patient that you suspect as hyperthyroidism, either they present with typical symptoms or with atypical symptoms, but now you now do the thyroid function test and it supports that the patient has hyperthyroidism, what next should you do, or what online investigations should you do? And it's important, these autoimmune markers are important. Don't forget what we said earlier, that hyperthyroidism, the commonest cause of hyperthyroidism is actually autoimmune, that's Graves' disease. Okay, but we have other causes as well. And those other causes as well that we have includes, we talked about solitary thyroid nodules, we have multinomal goiters, thyroiditis. Absolutely. So we have all of those other causes, and then you also have an idea that what is likely causing this your patient's hyperthyroidism, and that's where the autoimmune markers come in. Now, these are not done routinely, actually. Okay, the commonest one we'll talk about is the thyroid peroxidase antibodies, that's TPO antibodies. It's common. The assays are common, and you can easily get it done. It's classic in Hashimoto's thyroiditis, and it's almost synchronous with Hashimoto's thyroiditis. So you have, now don't forget that Hashimoto's thyroiditis is a cause of hypothyroidism in the long term. Okay, so if you have that and you find someone being hypothyroid and you do TPO come out with high titers or positive, you're dealing with Hashimoto's thyroiditis on the one stated. But it can also be found in Graves' disease. And by the time you have someone with hyperthyroidism who is TPO positive, it tells you that the hyperthyroidism you're having in that case is likely autoimmune in nature, and it's likely from Graves' disease. Okay, but the specific autoantibody for Graves' disease is one we call the TRAB antibodies, TSH receptor antibodies. So T for TSH, R for receptors, and AB for antibodies. So I don't write it there, but TRAB antibodies, and it's specific for Graves' disease. In fact, it's found in more than 95% of patients more than 95% of patients with Graves' disease. And if you find it, it's Graves' disease until otherwise proven. But you don't need to do that routinely. Why? Because Graves' disease usually you can diagnose clinically, and finding the TSH receptor antibodies in this part of the world, particularly, does not really change the diagnosis, does not change the treatment per se. It can help prognosticate a bit, but given the costs, I mean, if your patient can afford it, fine. Okay, so routinely we do TPO antibodies for them, particularly when it's not so clear. But by the time the patient has high signs, proptosis, periorbital edema, and all of those things, it's Graves' disease until otherwise proven, and you don't need to beat around the bush with this. But it's also indicated in pregnancy, because in pregnant patients with hyperthyroidism, which may be Graves' disease, but not definitely be Graves' disease, the titers of the TSH receptor antibodies can actually predict the risk for fetal thyrotoxicosis and guide some specific decisions to be made in that state. But those will be beyond the context of this presentation. Thyroglobulin antibodies. So note that the TSH receptor antibodies is also called thyroid stimulating immunoglobulin, TSI. So that's the old name, but these days we just call it TRAB. Okay. TG antibodies, that's thyroglobulin antibodies, is also common. It can be found in almost all sorts of thyroid diseases. We had a request for it. It's quite high in thyroiditis, so it's quite high in thyroid. Don't forget, in thyroiditis you have inflammation and destruction of the thyroid gland. Okay, thyroglobulin is actually part and parcel of the structure of the thyroid gland, and the antibodies to it go high when the thyroid gland is being destroyed. And so it's high in thyroiditis and other inflammatory and destructive thyroid diseases. But it's very important in monitoring thyroid cancer. In thyroid cancer, the way it's managed typically is that the patient gets radioactive iodine and also gets surgery, such that they expect any element of thyroid tissue in the person to disappear, okay? And the thyroglobulin levels should actually go very low. And when it becomes detectable again, it's suspect that there may be a relapse of the thyroid cancer. So that's just basically about the autoimmune markers. Again, the typical one that is done, if your TPO is positive, it tells you that whatever thyroid disease you're dealing with is likely going to be autoimmune, even though a certain proportion of the general population will be positive for TPO antibodies. But the one that is specific for Graves' disease as a cause of the hyperthyroidism is a TSH receptor antibodies, which is available. We do it in Cardiocare, okay? But it's not every patient that needs it. If the diagnosis is clear and the patient has eye sign that tells you already that this is Graves' disease, you really don't need to be pursuing the TSH receptor antibodies. So these are cath lab in Cardiocare. That's our cardiophysiologist and our cath lab scrub nurse. But the reason I put this slide there is just as a teaser, but we should also note that identified contrast, which is used for radiological investigations, including the cath lab, can actually trigger, can be a trigger for thyroid disease, okay, because it contains quite a big dose of iodine, and because of that, it can trigger through the, I think that's Jones-Basdo effects, okay, so that's just by the side, but that's our cath lab. Okay, going further now, so thyroid ultrasound scan. So we'll talk about functional tests for the thyroid gland. That's the thyroid function test. We'll talk about the autoimmune markers in patients that need it.
The weight imaging studies that can be done, which is the thyroid ultrasound scan.
Absolutely. And I think that the thyroid ultrasound scan, because it is non-invasive, it is easy to do, it is widely available, even though expertise may vary. But I think it's something that should be done. Even if you can't power, sometimes some patients have very chubby neck and you're not quite sure whether the thyroid gland is detectable or not. Please send them for a scan, and the sonologist will be able to tell you whether the thyroid gland in this patient is enlarged or not, or whether there are nodular areas or not. So I think that's very important. Importantly, also, it is important, it is more sensitive in picking nodules than our bare hands, okay? And in people that have goiters that you are wondering whether require fine needle aspiration cytology or not, there are certain criteria on imaging that can be found that can tell you or encourage you whether this patient is a candidate for fine needle aspiration cytology or not, okay? And now we have different patterns in thyroid adenoma, toxic mononuclear goiter, and Graves' disease. In Graves' disease, usually you have a diffuse enlargement of the thyroid gland with no necessarily focal nodular areas, even though we know that over time, they can begin after prolonged overstimulation of the thyroid gland by errant TSH coming from here and there. So over time, they can develop some nodular areas. Okay, so that's it. But generally speaking, thyroid ultrasound scan from Graves' disease just show some diffuse enlargement of the thyroid gland. Whereas in toxic multinodular goiter, you have, in Graves' disease as well, you also have increased vascularity of the gland, very much increased vascularity. And there's something called thyroid inferno on ultrasound scanning, which you just see on the Doppler scan, you just see red, everywhere, lots of vascular supply. That's supportive of Graves' disease. In toxic mononuclear goiter, what you tend to see is a lot of nodules, okay? Some of those nodules will be cold and hot. Of course, determining whether it's cold and hot cannot be done on ultrasound scan. That's a finding on thyroid scintigraphy, which we'll get to along the line, okay? In thyroid adenoma, you just have the thyroid gland being there like about normal, but a focal area can have a nodule, which is where it's producing the excessive T3 and T4, okay? Know that in thyroiditis, the vascularity is typically reduced. Don't forget what I said, that in vasculitis, there's inflammation, but after the first 2 or 3 days, the inflammation is receding and the vascular supply of the gland is actually much reduced. Why? Because the glands are not so functional at that time, and it's only the preformed hormone that you have in the systemic circulation that are producing the symptoms of thyrotoxicosis in that patient, okay? So we'll go to the next imaging now, which is the
thyroid scintigraphy.
So thyroid scintigraphy is a nuclear imaging
It's not very available in Nigeria.
It's not very available. So it's only available in a few centers, available in National Hospital, UCH, and a few centers, maybe 5 or 6 centers all over the country is where you have nuclear medicine. Hopefully, it should be available more and more over the years. Of course, we should know that nuclear medicine activities is tightly regulated by International Atomic Energy Agency because of the implications of nuclear-related technology. Okay, so it's tightly regulated. So, but the thyroid gland concentrates iodine, and because it concentrates iodine, you can use radioactive iodine as a tracer in the gland, okay? And you can now measure this also the patient is given a certain amount of iodine to take, usually intravenously, and it's concentrated by the thyroid gland, okay? And that imaging you can now see. So it's a functional imaging of the thyroid gland, unlike the ultrasound scan, which is just some sort of imaging which is not necessarily functioning. Exactly. So there are many tracers that can be used. Iodine 1, 2, 3, iodine 1, 2, 3, 1, forgive the cycle there, and technetium pertechnetate. Okay, so it's a functional scan to assess the thyroid, and it's very important. So the nature of the order of tests that is done for thyroid diseases varies all over the world, actually, and it's based. So in US, they tend to do thyroid scintigraphy very early. In many parts of the world, including UK, they go for ultrasound earlier. Yes, ultrasound will go for defaultly, and we hardly do scintigraphy to just evaluate the function and the structure of the thyroid gland, except when we're planning patient for thyroid ablative treatment or when we're suspecting cancer. Of course, in centers where they have this thing available, they will probably do it a bit more liberally, okay? So the practice just varies across various practices based on those factors. Going further now, so this is an example of imaging on thyroid scintigraphy. Okay, so imagine, let's know that this one here in the upper lobe is normal. In the upper row, middle gland is normal. So you can see to the left of this, the one gland in Graves' disease, you can see that the Graves gland is overactive, it's absorbing more iodine. Okay, you can see that it absorbs more iodine, and that's why the shadows are darker here. Now compare this to thyroiditis, in which there is reduced uptake all over the thyroid gland. Okay, you can see here, I hope you can see my cursor. You can see here in the thyroiditis, there's reduced uptake all over. Now this one down here on the right lower is as little bearing to our presentation actually. So this is someone that will have had a normal thyroid gland, but there's a part of the thyroid gland that is not uptaking iodine at all. That's a cold nodule. So that area of the gland is actually hypofunctional. Okay, so this person definitely needs a fine needle aspiration cytology of the area of that cold nodule. Now here you have a hot nodule. This is typical what you get in a solitary functional thyroid nodule or a thyroid adenoma. So you see that hot nodule, and this patient typically, for example, now if we are going to operate this patient does not require a total thyroidectomy, but a sub, just remove that place and has that place, might suffice. Okay, and we have this last one here that's toxic multinodular goiter. Now the typical picture is toxic multinodular goiter. You have a lot of hot nodules, but you also have cold areas. You can see the cold areas here. Okay, so you can see some cold areas, and that's how TMG behaves. So it just does a faster liver here. The person can even go euthyroid for a while, and then so they just misbehave, the nodules get hyperactive, and then some of them can burn out. And when those burn out, they can become cold areas that are hypoactive. I think this slide here, the borrowed slide, just shows the same features. Note that the uptake is generally reduced in subacute thyroiditis, and then the uptake is really increased in at least in the areas of the toxic nodules, and it's diffusely increased in Graves' disease, patching increment in TMG. So now we go to another investigation that is useful for patients with hyperthyroidism, and that's thyroid fine needle aspiration cytology, that's FNAC. So most patients with fine needle aspiration with hyperthyroidism actually will not require FNAC. Okay, why? We say because most malignancies are not hyperactive. Most thyroid malignancies are actually it's likely to be either euthyroid or hypoactive. That said, it's not written in stone. It's not written permanently like that. There are a lot of variations to this. Okay, so but routinely in patients with hyperthyroidism, many of them will not require thyroid FNAC. But if you have suspicious nodules on ultrasound scan, and that's why it's important to do ultrasound scan on this patient, or you did a thyroid nuclear scan and you can find some cold nodular areas, or you have the patient has clinical factors that are suspicious for malignancy, which we'll talk about some of those features along the line. Those patients should have thyroid FNAC done. So if you have a rapid growth of the nodule, so the patient told that this nodule was like this 2 weeks ago, and now it's like this. Oh, hold on. Consider for FNAC for those patients. If patients has hoarseness of their voice, so don't forget that it's when you have the glands now itself encroaching on the recurrent laryngeal nerve and causing hoarseness of the voice, consider doing FNAC for that patient. And of course, if you have on examination, your examination findings, you can see fixation of the thyroid nodules, some of the surrounding structures, or if you have lymph nodes that are suspicious around the thyroid gland, that should tell you that you should wonder whether your patient should get a fine needle aspiration cytology. Okay, and of course, in patients that have family history of thyroid cancer, for example, the patient I told you about earlier, or a patient that has any of the other familial endocrine neoplasia, such as MEN2 and some of the other endocrine malignancies, those patients should be considered for thyroid FNAC. Again, most patients with hyperthyroidism will probably not require fine needle aspiration cytology. Now, moving forward, excuse me. Moving forward, ECG. ECG important?
It's very important in patients with hyperthyroidism.
Right.
So the most common findings you see on the ECG is the sinus tachycardia, but we can also see other abnormal readings such as atrial fibrillation, which is more common in the elderly. So you should do that. You look for things also such as your atrial left ventricular hypertrophy features, which can with your criteria using the ECG. Then you can see something less common. You can see the atrial or ventricular extrasystole, some SVTs, the paroxysmal supraventricular tachycardia, or
atrial tachycardia as well. So those things are important, and I will encourage us all to make sure that in our patients with hyperthyroidism, we got an ECG for them, particularly the older subjects. Okay, don't forget that thyroid toxicosis is a sad cause of heart failure. Okay, but that means it was preventable basically, because and it's important for us to recognize when there are already some cardiac features so that we can know how aggressively we should manage such patients. Okay. So the ECG is important for virtually all patients with thyroid toxicosis. At least will have an ECG done. Okay. Now, echo is not all patients that require an echo. It's not all patients with hyperthyroidism, but if you have a patient with hyperthyroidism and then the patient has some cardiovascular symptoms, particularly maybe heart failure symptoms, you should get an echo. If you find atrial fibrillation in the patients, you should get an echo definitely. Atrial fibrillation, whatever is thought to be the cause, you should get an echocardiography. Why? You want to see the structural correlates of these things, whether the patient has heart failure or not. Okay. Of course, in older patients with thyroid toxicosis, I'll suggest patients 40 or 45 and above, please get an echo for them, because the cardiac complications may not be so prominent that you may not pick it up in history and examination, and it depends on who is taking the history or who is examining. And you don't want to miss that because it can influence your management, and you don't want to wait on the patient now has some NSAID, dilated cardiomyopathy, before we start to take something seriously as well. So of course, importantly on echo, we want to look for features of pulmonary hypertension, we want to see your E over E prime and co. We want to look for features of diastolic dysfunction, which is very common in patients with thyroid heart disease. And of course, heart failure with preserved ejection fraction is more common amongst them compared to heart failure with reduced EF. So seeing just a normal EF should not give you a false reassurance. Look very well at this echo and then let all the findings be clear. Okay. Okay, so this is just a reminder of what we do again in Cardiocare. Cardiocare is primarily a cardiology and internal medicine center. We have consultants, endocrinologists, we have consultant cardiologists, we have two interventional cardiologists, we have a neurology clinic, a regular nephrology clinic, and a pulmonology clinic as well. So part of what we do is interventional cardiology. We talk about pacemaker insertion, coronary angiography, cardiac devices, including ICD, CRT, that's cardiac synchronization therapy. We do these things routinely, with the aim of reversing medical tourism, really. So that means I see patients going week on week, going out of the country for, I don't know, for pacemaker insertion, pacemaker interrogation, and all these things that are doing routinely. So you do it more comfortably, close to your home, close to your family. So let's encourage our patients to avail themselves to these services that we do offer, and we can both make healthcare better in Nigeria. Back to our presentation. So treatments. So I think we're almost done. We'll be running up in the next 15-20 minutes, like 10-15 minutes actually. Please, let's continue to post our questions. I think we should answer some of these questions before we take the treatment, okay? So let's take some of the questions now. So someone asks, why does it affect females mostly? Does it also affect the balance and continuation of patients? So I don't understand that second question.
Coordination of the patient.
Oh, coordination. Oh, okay, I see. Okay, good. So why does it affect female mostly? It's a tough question, but my short answer to it is that Hormonal conditions actually affect females mostly. I think if you ask me, I would say that I'm just linking this one now indirectly. You know that females, we have that menstrual cycle, and that means female hormones are quite different at different time of the month. So they have that hormonal variation. I think that's give them a bit of vulnerability. So that's the main thing I'm going to say. But I'm not sure I would say that we know exactly the reason why thyroid diseases are more common among females. But hormonal issues are actually a little more common among females, and that's partly because they have more hormonal variability than males. Okay, so men, I'm sure if you check the testosterone levels and estrogen and LH and FSH level in the 30 days of the month, they'll probably be around the same value, whereas for females, it's quite different. So that might make them a bit more predisposed, but I'm not sure the other reasons why it affects females more is really known, truthfully. Okay. Now, I'll also add for females, another reason why females are more prone to hormonal issues is because of pregnancy that they go through. So nature gives some leeway for some hormonal change because the level of hormones you need in pregnancy and outside pregnancy is actually quite different. Okay. So because of those room for variability that is there, I think it just allows for disease processes to be more plausible. But I think it would be interesting to see people's thoughts and comments on this, but particularly colleagues are endocrinologists. Okay, so does hyperthyroidism also affect the balance and coordination of people? It doesn't typically affect balance, okay, but it can affect coordination because the tremor is a fine tremor and is not usually a debilitating tremor. Let me put it like that. So it's not like the tremor of benign essential tremor, idiopathic tremor, essential tremor. Let me remove benign from it like we have done, or tremor of cerebellar disease, which are often disabling, okay, or tremor of Parkinson's disease. So usually fine, not usually so disabling, but it can affect coordination in very severe cases, but not balance, okay? But even the restlessness and fidgetiness and anxiety that patient can have sometimes can be quite unsightly. Let me phrase it like that, okay? Someone asked now that how common is secondary hyperthyroidism? Beautiful question. I'll tell you that is not common at all. I think I've only seen one throughout for me so far, and I've seen maybe up to 2,000 or 3,000 cases of thyrotoxicosis. So it's not common at all. That's the truth. It's not common at all. In fact, out of all the secretory or functional pituitary tumors, the ones that are functional and producing TSH, they are rarer. So you're more likely to be producing prolactin, you're more likely to be producing the guy that governs ACTH, you're more likely to be producing all those guys, but for you to be producing TSH is just way less likely. So it's not so common based on my own experience, but it's very interesting to hear other people's experience as well. What are the warning signs of hyperthyroidism? Very interesting question. Well, I won't say warning sign. I think the key thing is just to pick up the non-specific, sometimes subtle signs. So when thyrotoxicosis presents with goiter, high signs, palpitation, sweating, even a medical student can diagnose it. But the job is actually to pick it in those relatively subtle cases, okay? The time I will use the term warning signs is actually maybe a patient has had it before, had a remission, and now having a relapse, okay? Also in pregnancy. In pregnancy, when it starts in pregnancy, people actually kind of miss it, particularly people that are first time being pregnant. So they might interpret it as maybe it's part of pregnancy, maybe it's because I'm pregnant that I'm feeling like this, that I'm getting fidgety, that I'm losing weight, or that my heart is pounding like this, okay? So they might misattribute it to it. But when we see those things, I think we should just have that high index of suspicion. And I think that will really help. Of course, sometimes in pregnancy, it might be a bit heralded by increase in size of the thyroid gland. But I'll tell us again that there's a physiological goiter that can happen in pregnancy. So the size of the thyroid gland actually increases a little bit on its own in pregnancy, which is normal. And that's just to make sure that the body is harnessing more iodine and producing enough thyroid hormone for both the mother and the baby. So I think I'll go to the next question. Can vitamin D or vitamin deficiency have a role in the development of thyroid disease and cause hyperthyroidism? My short answer to that would be yes. So many conditions in the body, both endocrine, autoimmune, and a vast range of conditions, even including diabetes, stroke, seizure disorder, and what have you, have been linked to vitamin D deficiency. So vitamin D deficiency can contribute to a lot of medical conditions. It has been reported that almost a third of the world population are insufficient in vitamin D. So it's usually classified into vitamin D sufficient, insufficient or gross deficiency. Okay, so yes, it will likely have a role, and it's always best to be as vitamin D replete as we can be. And we know the reason why a lot of people have vitamin D deficiency because of more indoor lifestyle. We're spending less time outside the sun. I can't remember the last time I spent an hour, or maybe our last Abuja as well.
Yes.
So that I work, but many times we're inside, particularly in this part of Nigeria where we're in northern Nigeria, where the sun can be quite harsh. So spending a lot of time inside is actually likely going to make us more vitamin deficient. I think there are a bit of papers on that actually. So linking vitamin deficiency, increasing the chance of people being having thyroid disease, including hyperthyroidism. But it won't likely be a cause, but it definitely will likely have a role in the pathogenesis.
Okay, so I said, can you live with hyperthyroidism without knowing? Also, can it be triggered by stress?
So yes, so stress, emotional distress, infections are part of the known triggers of hyperthyroidism. So yes, it can trigger it. Now, not causing it, it can just trigger it. And that means it's likely has been there before, the person was prone to it ab initio, and then that just ticked it up, okay? Yes, someone can be hyperthyroid without knowing, but gross hyperthyroidism usually have symptoms. That's the truth. You usually will have symptoms. Now, what is more common is that the symptoms may be misattributed to other causes. So you're losing weight and they just thought it was this dietary supplement you're taking, or it's because of work stress, like the patient I presented earlier. So that's actually like more common, but being asymptomatic with gross hyperthyroidism is just less likely. It can happen without a doubt, and we never say never in medicine, but it's just less likely. Now, someone can be grossly hypothyroid without really having a symptom. So it's more common for hypothyroidism to be asymptomatic compared to hyperthyroidism. Now, going further, how long will the treatment last? Very interesting question. So we're going to get to that, and we're going to discuss that along the line, actually.
Please, when would you stop
anti-thyroid medication? So I think that's the same question. So we need to make sure we address that. I think we can leave these questions for now and just pick it up here along the line. So let's go to the treatments now.
Okay.
So, so excuse me, just a moment here. So hyperthyroidism. So how do we treat hyperthyroidism? So hyperthyroidism is generally treated with anti-thyroid medications. Okay, but of course, a lot of things that are not on this slide, as we talked about, patient education, counseling, and then of course we should make sure that we sort out the patient's fears, make sure we get their expectations, etc. So generally speaking, the treatment is either we use anti-thyroid medications, radioactive iodine ablation, and of course surgery. So it's a combination of those three things. Okay, but and mainly in the UK as well, the first line treatment given is usually anti-thyroid medication. So we give anti-thyroid medications, and I'll tell you why we typically do this, okay? So we have three common anti-thyroid medications we use, which includes carbimazole, metimazole, and PTU, propylthiouracil. Metimazole and carbimazole are about the same thing. I think the metimazole is like carbimazole is like a prodrug of metimazole. So and in the UK, we use more of carbimazole, primarily, basically you can't find metimazole. In US, you use more of metimazole. PTU is available in all of those areas and is like a second line drug. So out of these two medications, out of carbimazole and PTU, carbimazole is agreed to be the first line medication. And the reason why this is so is not necessarily because of efficacy, but because the side effects, both of them can cause troublesome liver issues, okay? But PTU is more likely to cause that. And because of that, carbimazole is preferred as a first line medication rather than PTU, okay? So these are anti-thyroid medications, and the dose is generally based on a bit on the weight of the patient, but more importantly, the severity of the thyroid hormone derangements biochemically, not symptomatically, biochemically. So based on how much times the upper limit of normal you have, your T4 and your T3 will guide the dose of the carbimazole. And of course, the risk of side effects too, you balance it with that, okay? The drugs are usually well tolerated. We know that the most important side effect of carbimazole is number one, I mentioned liver inflammation earlier, which you can monitor in the head-axis. Rarely patient can develop jaundice. Of course, some patients can have pruritus or itching secondary to the medication. But we should not forget that hyperthyroidism itself can cause pruritus, can cause rash, can cause hyperpigmentation. Okay. Of course, very importantly, which we must all tell our patients is that it can cause agranulocytosis or granulocytopenia. So it can cause the granulocyte counts in the white cell counts to crash, and that can predispose your patients to all sorts of infection. So we tell patients that if they have a nasty sore throat or if they have an unusual sore throat, Some people say just ordinary sore throat, but so if anyone has a sore throat that is lasting longer than 2 or 3 days, patients will stop the medication and present to the hospital. Okay, stop the medication, present to the hospital. Usually, you need a baseline full blood count to see have a baseline white cell count. In Nigeria, sub-Saharan Africans, we have a lower white cell count compared to our Caucasian counterparts, and because of that, you should know the reference rate for sub-Saharan Africans. Okay, it's good to have a baseline for your patient so that if there's any story later on, you can have something to compare with. Okay, so that's carbimazole for you. You can give it in 2 divided doses for the day. Some people give 3, but I don't think that's necessary. PTU can also be used in select cases. PTU is typically preferred in someone that is not tolerating carbimazole, first of all, either from itching, and that's probably the commonest reason why we use PTU. We also prefer PTU, that's proprietary uracil, in the first trimester of pregnancy. The reason for that is that both, I think we'll go to the pregnancy part later. Anyway, we also slightly prefer PTU in thyroid storm, that's a thyroid emergency, which we'll go to along the line as well. Of course, because of the adrenalic symptoms the patients can have, and you know that what the antithyroid medication does is to interfere with the synthesis of T3 and T4 within the thyroid gland. And but don't forget what I said earlier, that we have a lot of preformed T3 and T4 in the thyroid gland itself already. So because of that, it will take quite a while before you have clinical benefits from starting carbimazole or any of the antithyroid medications. And because of that, you want to actually manage the peripheral symptoms, which is as a result of heightened sensitivity to adrenergic hormones, okay? And we do that by using beta blockers. And the preferred beta blockers are the non-specific ones that can give you both peripheral effects and the effect on the cardiovascular system as well. So classically, propranolol, typically use doses between 40 and 160 milligrams per day, but you can go even higher sometimes. We can also use atenolol, but propranolol is perhaps the most commonly used one. So here we combine that, and by the time patients get more thyroid along the line, we stop the beta-adrenergic drugs and then we continue thyroid medication. So typically we titrate. There are 2 kind of regimens to talk about, even though I didn't want to go into the details. So we have a up titration regimen. There's a name called it, I can't remember, but you start from a certain dose and then you titrate up. So that's the most commonly used regimen. There's also the so-called block and replace regimen, which is less commonly used, and I don't use that. And so in those block and replace regimen, use a very high dose of the antithyroid medication, and you treat the person to being hypothyroid. And when the person becomes hypothyroid, you now replace with some levothyroxine while maintaining the very high dose of the antithyroid medication. But he has his own risk, more risk of side effects, more costs, even though he has his own proposed benefits as well, which we might go into along the line of this time. Okay, so we can also have thyroiditis. Now, I said earlier that thyroiditis can cause thyrotoxicosis, but technically it's not a cause of hyperthyroidism. It's important for us to recognize thyroiditis, and I think I emphasized it along the discussion. In thyroiditis, there is tenderness of the thyroid gland, either at the time you're seeing the patient or sometimes along the course of the illness. So once you have a patient having symptoms of thyrotoxicosis, plus or minus a goiter, and there was tenderness in the neck, in the thyroid area, please, that is thyroiditis, and you should manage as such. In thyroiditis, we avoid antithyroid medication. Why? In thyroiditis, the thyroid gland is hot and is inflamed, it's sort of damaged, so to say. Production of thyroid gland is already down. Sorry, production of thyroid hormone is already down. It's already slammed down, okay? The things you're getting into the periphery are just the already preformed hormones that are just released into circulation. So there's no need for you to cut further thyroid hormone production by using antithyroid medication. Rather, you actually want the thyroid gland to recover and begin to be able to produce further thyroid hormone. So in people that have to manage conservatively, thyroiditis, when we say thyroiditis now, we're usually not talking about Hashimoto's, so put that on one side. So thyroiditis is usually self-limiting, and so it's self-limiting. So if there is pain, we treat with analgesic. If pain is no longer there, okay, that's fine. You just manage the patient conservatively, basically, and you monitor the patient, okay? One of the things I didn't mention earlier, I'm not sure I mentioned those investigations, but in thyroiditis, one of the key things that help your diagnosis is, of course, your imaging can help, both imaging in form of ultrasound scan and thyroid scintigraphy where available, okay? Also, your inflammation markers are important, okay? ESR, C-reactive protein, typically will be elevated in thyroiditis, okay? And in your blood count, you can tell If it's predominantly neutrophil, can suggest maybe it might be infective, maybe bacteria, but more often than not, it's not infective and it's not from bacteria. And then you might have just maybe lymphocytic preponderance or a normal full blood count. Again, like I said, it's typically self-limiting. Initial initial time toxic phase. Later, the patient goes hypothyroid, and then later they get back to being euthyroid. And these phases, you may not see any of the phases. Sorry, we say the hyper phase or the hypo phase, you may not pick it, okay? And then how long they last is quite variable. It might last months, might last up to even a year before the patient gets euthyroid, okay? But typically, in thyroiditis, we avoid anti-thyroid medications. Moving on. So how do we monitor patients on treatments?
So before you start the treatment, you must do a full blood count.
Okay, absolutely. We talked about having a baseline full blood count along the line.
Yeah.
Because of a few cases of thyroiditis and other autoimmune manifestations, it's good to have an ESR when you have diagnosed a patient with hyperthyroidism. Okay. It's also important to have a baseline liver function test because I mentioned earlier that the
part of carbimazole.
Absolutely. So the antithyroid medications can have liver side effects, and we want to have a baseline to be able to compare to. Now, you don't need to monitor full blood counts or LFCs while on treatment. No, not really. You just have it as a baseline so that if you have issues later, you can have something to compare with along the line. Okay. But of course, in people that if you define, maybe you thought you had thyroiditis and then the ESR was elevated, it's good to monitor that. But for the thyroid function itself, you should monitor every 4 to 8 weeks. Okay. In patients with just mild amount of hyperthyroidism and fairly, you can do it weekly, but usually it's better to check every 4 to 6 weeks. In very sick patients, you should check often. Okay. Someone asked earlier about the duration of treatment, and the duration of treatment for patients is having thyrotoxicosis from hyperthyroidism, especially from Graves' disease. We want to put on anti-thyroid medications for about 12 to 24 months. For about 12 to 24 months, so that's 1 to 2 years. Now, that is not a universal practice. I have to say that. Okay, and practice varies differently in different parts of the world. In US, they tend to do radioactive iodine ablation very early. Okay, they can almost send you to do ablation yourself just at the time of diagnosis. Just go and have a thyroid gland ablated and be perpetually on levothyroxine, lifelong replacement subsequently. Okay, but the reason why we do this is that amongst patients with hyperthyroidism, also immune hyperthyroidism, a good fraction of them will enter into remission. Maybe about 2 to 5% will enter into a spontaneous remission. That's one. Secondly, there are some of them that is actually thyroiditis that they have, but that you missed it. Okay, so it gives you the window to see those patients follow up along the line so that you don't give definitive treatment to a patient that does not need it. But most importantly, the antithyroid medications we use, particularly the carbimazole and metimazole, they have some immunomodulatory properties and they increase the chances of full remission in the patient actually. And we know that on antithyroid medications, about 20, in some series up to 40% of patients will go into remission while on those medications. That's within your 1 to 2 years. Okay, so it's good to identify those patients that are going into remission. And right now, I have a lot of patients in remission actually. Okay, and you don't need to offer them surgery or a permanent ablation of the thyroid gland. Okay, so during those periods, we identify those patients, and then patients that continue to require treatment after 1 to 2 years, we should offer definitive treatment. And the definitive treatment is usually in the form of surgery or radioiodine ablation. Now, I mentioned earlier that people can go on remission. When patients in remission, technically, they will remain euthyroid, even despite going off antithyroid agents, okay? So having your patients controlled, that is, they are on antithyroid agents and their hormones are controlled, and thyroid function test is fine. That's not remission, no. Okay, remission means that they continue to require less and less doses of the antithyroid medication, and then finally you took it off, and the patient remained euthyroid for 2 months, for 3 months, patient remained euthyroid, so you can say that clinically that patient is in remission. Unfortunately, most of the patients are going to remission, a lot of them will actually relapse, okay? That is, they will continue, they will start to have the symptoms again, and then you have to place them back on medications. Once that happens, please plan the patient for definitive treatment. Now, we have 2 forms of definitive treatment for patients, and it's often a subject of discussion. It will continue to remain a subject of debate, and patients generally have those 2 options. So when you tell them about and it's important to discuss definitive treatment with the patient ab initio at the outset, tell them that they may require this kind of definitive treatment. Let them know, and then let them, so that it's an ongoing discussion, so that when it gets to that point, it doesn't come to them out of the blues. Okay, so patients have the option of radioactive iodine as a definitive treatment to ablate the thyroid gland or surgery to remove the thyroid gland. So I'll just compare those two for you in a bit now, okay? So we have radioactive iodine, we have surgery. Sorry, the order of comparison is not the best, but we'll just manage this for now. Okay, so radioactive iodine, let me just tell us a little bit about it. So again, radioactive iodine is a procedure in which a patient or someone that has overactive thyroid, we give them a radioactive form of iodine that is taken orally, concentrates into the thyroid gland, and it emits radiation that ablates, that literally blasts of the thyroid gland, okay? Blast of the thyroid gland, of course, it goes into continuing the thyroid gland usually within a few hours of swallowing it, okay? But the process of ablation takes a while, maybe a few days, and then for thyroid gland hormone synthesis to go down and then eventually stops and actually take weeks to months, okay? So that's radioactive iodine therapy, and a lot of things surrounding it. I've told us earlier on that nuclear medicine service is only available in controlled pockets in the country, okay? So in people undergoing radioactive iodine therapy, because of the radioactivity that has happened at that time and that some components will remain in their body for a while, they should not get pregnant. Females should not get pregnant for up to 9 months after that treatment. It's not that they cannot get pregnant, they should not get pregnant. That means they should be on solid contraceptive agents, okay? Otherwise, teratogenicity can be an issue. Males should not get pregnant, should not impregnate someone for 3 to 6 months after that. I think up to 6 months, if I remember correctly, okay? So in patients that tell you that, I just married last year, February, I must get pregnant next month, I cannot wait for 9 months. I know I cannot. Okay, those ones can tell them so we should have that in mind. Of course, I've explained just now that if a patient undergo radioactive iodine ablation, you don't get euthyroid immediately, okay? It can take weeks, even to a few months before the thyroid hormones just gradually gets to zero, okay? Or gets to very low. Whereas after surgery, once you didn't have the thyroid gland, now the thyroid, any source of thyroid hormone in the person is actually gone, okay? I talked about limited availability of radioactive iodine centers in the country earlier on, whereas surgery is more widely available. You need less preparation for radioactive iodine, and in a patient that is still thyrotoxic, that is, you've not gotten the patient euthyroid, the patient can go for radioactive iodine. Indeed, they actually want the patient to be toxic. So in patients that are actually euthyroid that are on medications, we tell them to stop their medications for up to 2 weeks before they have the procedure done. Why? Because if you are suppressing the function of the thyroid gland, it will not uptake the iodine both for scanning and for therapeutic purposes. It will not uptake it. Okay. Whereas a patient going for surgery needs to remain euthyroid. This consideration is important for patients that are struggling to get to euthyroid state, because sometimes some patients can have some difficult thyrotoxicosis, and that either because of adherence issues or because of other components of their disease, can be difficult to get them to euthyroid state. Okay. Of course, there are some concerns about radioactive iodine with cancer, even though these concerns have been laid to rest over the decades, but patients still get really worried actually about radioactivity related treatment. Of course, there are surgical risks to surgery, like for every surgery, and risk of damage to recurrent laryngeal nerve, parathyroid damage to parathyroid gland. So that is like bleeding that can lead to even death sometimes. So those risks are there. Those risks are way less with radioactive iodine. Of course, with radioactive iodine, we see that patients have severe thyroid eye disease. Radioactive iodine therapy can actually slightly worsen the eye disease, sometimes slightly, but there are things that can be put in place to minimize the risk of this, okay? Of course, there's always a risk of incomplete ablation with RAI, particularly if the dose that was used was quite conservative. In surgery, if it was a total thyroidectomy, there's no risk of recurrence at all, okay? But when a subtotal is done, there's a real risk of recurrence, okay? And many surgeons do subtotal. Now, for both of them, patients compare this a lot, whether they need to go on lifelong levothyroxine. For both of them, generally speaking, you have to, except when they do subtotal thyroidectomy. But the risk with doing a subtotal thyroidectomy is that there's a solid risk of recurrence of hyperthyroidism, because the TSH stimulation that happens to the old thyroid gland before can happen to that small one that was left, and it can grow big. It can go very big. And reoperation of the thyroid gland is usually a little bit more difficult than the first operation. So those are factors to consider for our patients. I know it's not as detailed as we want it, but we are mindful of time. So just a few more things to talk about, to touch before we complete the presentation is thyrotoxicosis in pregnancy. Thyrotoxicosis is very common. It's quite common in pregnancy. I'm not sure how many we have seen before, but it's quite common in pregnancy. And treating it is actually sometimes a bit tricky, okay? So thyroidism is common in pregnancy. We call it gestational hyperthyroidism for the ones that start in pregnancy. Of course, you can have patients that have Graves' disease, which causes subfertility, but by the time you now treat the person well, the person got pregnant, and then you wonder whether you should continue treatment or you should stop treatment. So you have to continue treatment, okay? So, but the mechanisms of thyroid disease in pregnancy, of course, there's genetic predisposition, which is part and parcel of hyperthyroidism generally. Okay, but we also know that the hormonal changes, which I talked about when I was trying to explain why thyroid diseases are more common in females. Those hormonal changes in pregnancy, particularly related to HCG, can trigger onset of thyrotoxicosis. Okay, and of course, we know that autoimmune conditions, some of them get better in pregnancy, some get worse in pregnancy. For thyroid disease, typically actually get worse after pregnancy. Okay, but the chance in pregnancy is actually still higher compared to the regular population. Okay. We should not forget that TFT requires specific interpretation in pregnancy, particularly TSH. TSH in early pregnancy can be falsely very low, and that's because of the effect of the beta HCG, which sort of like mimics the TSH. So there's a premises-specific interpretation of TFTs in pregnancy, and even though we don't have enough data for Nigeria, but we were usually still able to extrapolate. I've talked about beta HCG stimulating the thyroid receptors, the TSH receptors, and which is part of the mechanism of the thyrotoxicosis in pregnancy. And I did mention earlier that in people that are thyrotoxic, it reduces their fertility, so it causes subfertility. But it can also increase risk of early trimester pregnancy loss and even IUFD late in pregnancy. Okay, I didn't talk so much about fetal thyrotoxicosis and fetal goiter, which is an issue, especially in mothers that are positive for the thyroid TSH receptor antibody. So we should put that in mind, okay? So that's a thyrotoxicosis in pregnancy in a nutshell. I did mention earlier that PTU is preferred in the first trimester, and usually in second and third trimester, we change to carbimazole. But the way we treat thyrotoxicosis in pregnancy is different from outside pregnancy. We don't want to risk. Okay, so we don't want to risk any amount of hypothyroidism at all. Okay, so before I get to that, so both carbimazole and PTU crosses the placenta, we should be aware of that. I did mention earlier that carbimazole is slightly, just very slightly more risk for teratogenicity in the first trimester, and because of this, we prefer PTU in the first trimester. You want to avoid hypothyroidism at all costs in pregnancy. Why? Because of the consequence of fetal hypothyroidism is intense. It can cause mental retardation, which I hope we should all be aware of. And because of this, you should err towards slight hyperthyroidism than slight hypothyroidism in pregnancy. That's in the way you are managing and interpreting your thyroid function test. And of course, in pregnancy, when you're treating people in pregnancy, you need to monitor your thyroid function test more frequently, typically 4 weekly. And then, of course, it's important to check the thyroid TSH receptor antibody in pregnancy. And then in patients that are positive for that, we need to check regularly for neonatal goiter, fetal goiter or fetal thyrotoxicosis. So that's a typographical error. So I think we're rounding up here. So this is last slide. So I'm not sure how many of us have heard about thyroid storm. Have you seen a patient with thyroid storm before?
I haven't, but I've read it about.
Okay, so we have seen someone about maybe 6 or 7, 8 weeks ago with imminent thyroid storm. There's a criteria that we use to make the diagnosis. So sometimes it's imminent, and then sometimes it's probable, and sometimes it's confirmed, depending on how much of the features we have. Okay, but basically, thyroid storm is a endocrine emergency. We say is also called thyrotoxic crisis. So it's just a very severe form of thyrotoxicosis. Okay, so exacerbation of the signs and symptoms of thyrotoxicosis. It's important for us to note that it's not due to the level of thyroid hormone itself. So someone that has thyroid storm will not necessarily have more T3 and T4 compared to someone that doesn't have thyroid storm. You understand what I mean, Abi? So it's not that it's not diagnosed by the hormonal level. No. So it's just actually more of the sensitivity to those hormones and sensitivity to the adrenergic hormones actually make someone have those features. And it's quite common after surgery, after radioiodine ablation, and after intercurrent illnesses as well. So someone with thyroid, thyrotoxicosis, had malaria, or had myocardial infarction, something can tilt them into thyroid storm and you can start to see the picture. And it's central, the central thing to see is hypermetabolism, fever, sweating, excessive adrenergic response, serious tachycardia, often exceeding 120 or 130 per minute. They can have fever, they can have restlessness, they can have delirium, they can have diarrhea, nausea, and vomiting, and sometimes they can have jaundice as well, okay? And as I said, yes, the thyroid hormone level is high, but it's actually more related to the increased level of circulating catecholamines in this patient. It's a medical emergency, require acute care, requires IV fluid, requires antithyroid medications, requires beta blockers, preferably the peritoral ones, and then other supports until the patient recovers.
Thank you, everyone.
In summary, we have discussed hyperthyroidism. We talked about a bit about the epidemiology. We talked about recognizing it, how we will need a high index of clinical suspicions. We talk about how to evaluate a patient with hyperthyroidism, and it's not just thyroid function tests. No. So don't just thyroid function test for a patient and then slam the patient with medications. No. I've actually reminded us to check how to suspect thyroiditis. If you have pain or tenderness, you suspect thyroiditis. And of course, we talked a bit about other imaging modalities, thyroid ultrasound scan, thyroid scintigraphy. We also talk about some things about how to treat a patient with thyrotoxicosis. So thank you very much for joining us. We'll take more of these questions now. If you want to speak, audibly, you can raise your hand, we can allow you to talk. But I think we'll take the rest of the question now. So someone asked earlier that how long does the treatment last? So I think we've answered now that the treatment typically on anti-thyroid medication is for 1 to 2 years, okay? And we usually, the medication are not just to be stopped, we titrate up and titrate down based on the response to the treatment. And sometimes you titrate down to the extent that you stop the medications and then you continue to monitor the patient. So if the patient continues to get relatively hypothyroid on less and less dose of carbimazole, you can get to a point that you stop the carbimazole entirely, and the patient remains euthyroid and stopping carbimazole up to 3 months so that the patient is in remission, and then you continue to monitor the patient. A question here says that does the fact
that women are more prone to autoimmune disease contribute to the increased risk of thyroid disease?
I absolutely agree with that. Yes, so it does contribute to it. But of course, on the other hand, even the so-called endemic goiter, this iodine deficiency, is even more common among females as well. So, and that is not autoimmune. So it's both ends actually. So the fact that hormonal issues are more common among females, and of course because females are. So I thank you for this contribution, Dr. Adizabelo. So that they are more. So the fact that they are more prone to autoimmune disease is also very contributory. So what's the drug of choice, and what informs the use of the other drugs? So I think we talked about that a bit. Okay. So here, carbimazole is a drug of choice, and the reason why it is a drug of choice is that compared to PTU, it is less hepatotoxic than PTU. They're both clinically efficacious. PTU is slightly prevalent in thyroid storm because of the additional benefit of PTU interfering with peripheral conversion of T3 to T4, which causes theoretically a more rapid onset of action for them. And I've also discussed the rationale for the drug of choice in pregnancy. I've said that PTU is preferred in the first trimester because both of them are teratogenic, but carbimazole is slightly more teratogenic than PTU in first trimester. But if you can't find PTU and it's commonly scarce, you can actually still use carbimazole in post pregnancy, following all the caveats. But I'll strongly recommend that treatment of thyrotoxicosis generally, but more particularly in pregnancy, should be under the direction of an endocrinologist without a doubt. So going further here, can slight abnormalities in TFT result in significant symptoms? Now, that's a very good question. So many times you get, now it's important to be able to interpret thyroid function tests appropriately, but sometimes you get some non-specific symptoms, non-specific changes in the TFTs due to maybe just some unexplained hormonal fluctuations on one side. Sometimes can be due to what we call sick utero syndrome or non-thyroidal illness, so to say. Okay, but when we're interpreting thyroid function tests, it must always be in the context of symptoms. It must always be, and you must ask what symptoms of the patient have what were you suspecting before? Don't forget that many of these assays that are done, particularly in this part of the world, may not necessarily be perfect. And that's why our clinical acumen actually has to come into place, and you have to now interpret that result in the context of your patient. So yes, can slight abnormalities be related to symptoms? Definitely, yes, it is. Don't forget that we talk about a general reference range, but what that person's T3 and T4 was 2 or 3 months ago, we don't know. You could have been lying in this 25th percentile of the reference range before, and has suddenly jumped to 75th percentile, 80th percentile, and is having some symptoms, and you just feel that that result is normal. No, so it must always be interpreted in the context of the symptoms of the patient.
The next one is, would one still consider a 40-year-old man with palpitations, poor sleep, sinus tachycardia on ECG, and an elevated TSH as hyperthyroidism or hypothyroidism? Okay,
so we need to, so I'll encourage us to read that chart, which is common online as well in interpreting TFTs. So elevated TSH is consistent with hypothyroidism, not hyperthyroidism. Elevated TSH is consistent with hypo, that's too low thyroid, not too high. Now, the symptoms we say this man has is palpitations, poor sleep, and sinus tachycardia, which I suspect when you check the TFT, they are probably looking for hyperthyroidism. So that means the thyroid TFT changes does not explain the patient's symptoms. Shaking, that's for that, okay? But now the apparent hypothyroidism that is there now needs to be evaluated on its own merits and see whether there are clinical correlates of that, and you should decide whether you want to treat the person for that incidental finding or whether you want to just watch and repeat after 8 to 12 weeks, okay? So that's a judgment to be made. So the last question asks that, does hyperthyroidism get worse with age? Interesting question. What food intakes make thyroidism worse? And we would like someone to answer this, please. So can you try to answer that, please, Dr. Obi?
Okay, so does hyperthyroidism get worse in age? It is more common in some age groups, in the elderly, and also we should have a high index of suspicion when we are seeing this age group and all. But you cannot say that as progresses it gets better.
I agree with that. I agree with that. So hyperthyroidism is more common in the reproductive age group, like we said earlier. It's less common at the extremes of age.
Yes. Then also, what food make hyperthyroidism what food makes thyroidism
or thyroid disease worse?
Right.
I think
okay, so as we already pointed out earlier, we already know that iodine is very important in the production of thyroid hormones. So if you are hyperthyroid and you're taking foods rich in iodine, you can expect your body to produce more,
absolutely,
which can affect that. So that's one of the food groups you should just read. Like salt is a very more, anyone that can.
Absolutely. So I think I'll remind us to that particularly people that take a lot of supplements. When we're taking history of someone that's presenting with hyperthyroidism, one of the things we need to ask about is supplements. There are a lot of supplements that contain seaweed or that contains very high dose of iodine, which can trigger hyperthyroidism in patients. So I think that's a very good question actually. So some food items can make hyperthyroidism worse and can also trigger hyperthyroidism, particularly medical supplements.
Then could you please repeat the treatment regimen for hyperthyroidism?
Okay, so when we see patients with hyperthyroidism, we want to educate them about the diagnosis and the course of the treatment, because that's important. And we did say that typically one of three things, a combination of three things that is used: anti-thyroid medications,
surgery, or
radioactive iodine. Absolutely good. So, and I said that in this part of the world, anti-thyroid medications are typically the first line treatment that is offered to a patient with hyperthyroidism or thyrotoxicosis. So anti-thyroid medications, we have three main anti-thyroid medications: carbimazole, metimazole, and propylthiouracil. And in this part of the world, generally speaking, the preferred agent is the carbimazole, which is also like the same thing as metimazole actually. Okay, so that's offered to the patient. And if a patient continues to require treatment after being 1 or 2 years on this medication, definitive treatment should be offered. Definitive treatment is in the form of radioactive iodine or surgery. And usually we give the patient the pros and cons of all the components, all the types of treatments, and we allow them to make their choice.
So the next one is, I want to know the iodine isotope for radioactive iodine. So I think we mentioned that one, the iodine 21, I31. Then we have the 10.
So yeah, so you mentioned those earlier, beautiful. So we mentioned the iodine 123, iodine 131, and the technetium, I think it's 98 per technetium.
Titanium, technetium something. So the next question, thank you very much for an, you can see, for an excellent presentation. What is the role of liver function test in hyperthyroidism? And can digoxin be used in the treatment of the heart failure? And what's the role of steroids in the management of hyperthyroidism? So this is a three-part question.
Just answer the first part.
So thank you. We've already said that we do a liver function test as a baseline. As we know, we start at carbimazole and propyltyrosine, which can affect the liver function test. So which some of the side effects affect the liver function, causes jaundice. So you just have to do it and have it as a baseline. So if some of these complications arise in present, we can then use it and compare.
Okay, so that's one. And then secondly, we did mention so that in severe thyrotoxicosis or thyroid storm, they can have changes in their liver function. In fact, they can also have jaundice as well. So those are the two roles. Those are the two main roles in hyperthyroidism. I think I'll try to answer the next question. Can digoxin be used in the treatment of the heart failure from thyrotoxicosis? Yes, it can be used. So of course, the main peculiarity of the heart failure of hyperthyroidism is that the thyroid disease needs to be treated. Very importantly, thyroid disease needs to be treated, and we should be aware of drug-drug interactions. That's two. We should also be aware of the other effects of the other organ systems apart from the heart. Okay, the heart failure treatments there needs to be treated just along the guideline-directed medical therapy. Okay, of course, digoxin will not be a first-line medication in this case. Okay, but if a patient has atrial fibrillation, for example, and heart failure, there may be a role for that. So, so we just follow the guidelines for heart failure in this regard. Fortunately, thyrotoxic related heart failure is often reversible. By the time you remove the excessive adrenergic catecholamine stimulation of the heart and all of that, typically the heart failure usually gets better. Can you answer the last question? What's the role of steroids
in the management of hyperthyroidism? We didn't mention that.
Okay, so we didn't talk about steroids during the management actually. So steroids has a role in management, even though it's more of advanced or expert use are now here along this line. So few roles. So in T3 toxicosis, sometimes we have to use steroids in patients in which they remain toxic despite using the highest doses of the carbimazole or the antithyroid medications. Of course, it also has a role in in thyroid storm. So in thyroid storm, most of them will get steroids as well, just to help an acid recovery as well. And then we should not forget that Graves' disease the dominant cause of hyperthyroidism, that's Graves' disease, an autoimmune condition. And when you have that, there may also be other autoimmune conditions, including Addison's disease or other autoimmune cause of adrenal insufficiency, in which you may need to replace the steroid. So those are the clinical compositions of the role of steroids in many of hyperthyroidism. So, but the most common one that will probably happen will be between the first two, when I mentioned that in patients with severe thyrotoxicosis and thyroid storm, that's one. And then two, importantly, in patients with difficult, intractable hyperthyroidism or patients with intractable T3 toxicosis, sometimes we may need to use some steroids, but that would be at expert level.
Okay, I think we're almost done.
Yeah, absolutely. So we have just a few more questions here. What's the effect of hyperthyroidism on anxiety? This is a very important question.
Yeah, it is we talked about it, that most of the symptoms that present in they usually misdiagnosed as anxiety disorder. The patient has palpitations, tremors, and the tremors, they have palpitations.
In fact, they have anxiety as well. So hyperthyroidism is a cause of anxiety, causes anxiety. Anxiety is a symptom of hyperthyroidism. That's one. So it can mimic anxiety disorder, and the patient can be wrongly treated for just anxiety alone, whereas there's hyperthyroidism that is locking on that. And of course, if someone has anxiety disorder already and has hyperthyroidism on top of it, it will make it worse. Okay, and if you don't treat the hyperthyroidism component, we're just going to be giving the patient just a little component of the treatment. Okay.
Okay. So thank you.
Okay. So any other questions? Okay, so the remainder just comments. So thank you very much, our audience. Someone said we should recap the use of radioiodine treatment. So I think it's wonderful for me to go over that. We're out of time. Sorry that we stayed too long. So again, radioactive iodine treatment is one of the definitive treatment for thyroid toxicosis or hyperthyroidism. Okay, it takes a gland that is overactive to take radioactive iodine very well. So usually radioactive iodine is done by nuclear medicine units, and they have a few all over the country. The radioactive iodine is taken orally, actually. It's prepared especially for the patient. They first of all do a dosing scan for the patient, scan the thyroid, and determine the dose that the patient required. That specific dose is made for the patient in a capsule, and the patient is taking it in a controlled environment, okay? When it's takes it in a controlled environment, in that controlled environment, the patient does not limit exposure to other people, because the thyroid is literally emitting radioactive whatever that rays at that time, okay? The patient takes that, and the patient progressively gets hypothyroid over the next days to weeks, and that's okay. And of course, after using the appropriate dose, the patient will get hypothyroid, and the patient will require lifelong thyroid replacement, just like a patient that had total thyroidectomy will. So that's basically the recap of radioactive iodine. I mentioned earlier that usually the patient was euthyroid before, usually the anti-thyroid medication will be stopped for a while so that patient's thyroid can get back to being overactive, and that we can be sure that the patient will uptake all the iodine that we supply to the system. Once again, thank you very much.
Thank you.
The webinar is being brought by Cardiocare Multispecialty Hospital. My name is Dr. Awofisoye. With me here is Dr. Vivian Obi. And thank you, our audience, for being engaging. I think subsequently we'll be trying to make sure that we have verbal components so that people can actually talk audibly. I think it's to make it much more interesting. In Cardiocare, we practice internal medicine. And one of the things we offer our partnering doctors is that we give you what we call a referral medical report, such that you have a written feedback on any patient you refer for any of the internal medicine specialty. And we are willing to collaborate with you actively in the care of your patients, so that your patients get better, and then you're able to continue the care seamlessly. Okay, so we do a lot of cardiology. We have five cardiologists here, so we do a lot of cardiology, a lot of interventional cardiology. I'm an endocrinologist primarily. We have a rheumatologist, pulmonologist, GI doctor, and two nephrologists. Okay, so we do that. We have dialysis service. We also have a cath lab where we do coronary angiography, stenting, balloon angioplasty. We do peripheral angioplasty for diabetic foods, for peripheral arterial disease. We do catheter-directed thrombolytic therapy for massive pulmonary embolism, or for other pulmonary embolism that have hemodynamic disturbances to warrant such therapies. So a lot of this collaborative care is quite helpful, so that the services that are not available in every center, we are a center of excellence for some of these things, and then we can collaborate, send your patients, get those components of treatment for us, send the patient back, and then you continue the care from there. Of course, we do other investigations, including stress ECG, stress echocardiography, ambulatory blood pressure monitoring, ambulatory ECG, EEG, spirometry, and all the work. So once again, we're happy to have you. We're happy to have these discussions and to broaden our minds and to sharpen our minds concerning these internal medicine topics. Sometimes next one we're going to have another topic.
Yes.
Absolutely. So it's been wonderful having you guys here. Thank you for being a wonderful audience, and do have a wonderful weekend and a wonderful evening.
Bye, everyone.